If you're taking vitamin B12 right now, pause for a second and think about what else you took today. Not just one thing, everything. Because after 60, it's not the vitamin alone that causes problems. It's what it mixes with. And I've seen this more times than I can count. A patient once sat in front of me doing everything right, taking B12 for energy, following their prescriptions, staying consistent. Yet something felt off. Fatigue didn't make sense. Irregular heart sensations, slower recovery. And when we looked deeper, it wasn't one mistake. It was a combination no one warned them about. Here's the part most people never hear. After 60, your body doesn't process medications the same way. What used to work together quietly can start interfering with each other. And B12, as simple as it sounds, can react differently when paired with certain common medications. The dangerous part is you don't feel it immediately. It builds slowly, small changes in energy, subtle shifts in how your body responds, until one day it becomes noticeable. And by then, most people have no idea what caused it. I've seen patients take the same routine for years, thinking they were helping themselves, while something underneath was working against them. Not because they were careless, but because no one explained how these combinations actually behave inside the body. In this video, we will reveal 5 common medications you should never combine with vitamin B12 after 60, ranked from the least risky to the most concerning. And the number 1 is something millions of people take every single day without realizing the impact. If you're wondering where this comes from, I've added the details in the description below. Before we dive in, here's a quick question. How old are you and where are you watching from? I read every comment, and I truly want to hear your routine. Now, let's begin with number 5, because this one is more common than most people expect. Number 5. Colchicine. Colchicine is one of the oldest medications still in use today, and millions of adults over 60 take it regularly to manage gout flare-ups and certain inflammatory conditions. It works by reducing the swelling and pain that comes when uric acid crystals build up in your joints. The problem is that colchicine directly interferes with your body's ability to absorb vitamin B12 from the small intestine. Your gut lining has specialized receptor cells called cubolin receptors that grab onto B12 molecules and pull them through the intestinal wall into your bloodstream. Colchicine disrupts this entire transport system. A study published in the American Journal of Clinical Nutrition tested B12 absorption rates in patients taking colchicine for more than 3 months and found that absorption dropped by roughly 40% compared to a control group not taking the drug. That means even if you are swallowing a high-dose B12 supplement every single day, your body might only be receiving a little more than half of what it normally would. Over time, this creates a slow creeping deficiency that can take months or even years to show symptoms. And the symptoms, when they do arrive, often get blamed on aging itself. You start feeling more tired than usual. Your memory gets foggy. You notice tingling or numbness in your hands and feet. A 2019 case series in the British Medical Journal documented 14 patients over 65 on long-term colchicine therapy who developed significant B12 deficiency with neurological symptoms, and in 9 of those patients, the nerve damage had already become partially irreversible by the time it was caught. The critical thing to understand is that if you must take colchicine, you should separate it from your B12 supplement by at least 4 to 6 hours and ask your doctor about monitoring your serum B12 and methylmalonic acid levels every 6 months. Methylmalonic acid is a more sensitive marker than B12 blood levels alone because it rises early when your cells are not getting enough B12, even if your blood levels still look normal. Some physicians now recommend sublingual B12, which dissolves under your tongue and bypasses the gut absorption pathway entirely for patients who cannot stop colchicine therapy. This simple switch can make a dramatic difference in maintaining adequate B12 status while still keeping your gout under control. Now, if colchicine surprised you, the next medication on this list is one that almost every household has in the medicine cabinet right now. But before we continue, If you have been enjoying the video so far, hit the like button and don't forget to subscribe and hit the bell icon so you don't miss more videos like this. Number 4. Proton pump inhibitors. Proton pump inhibitors, commonly known as PPIs, are among the most widely prescribed medications on the planet and include drugs like omeprazole, lansoprazole, and esomeprazole. Doctors prescribe them for acid reflux, heartburn, stomach ulcers, and gastroesophageal reflux disease. They work by shutting down the tiny acid pumps in your stomach lining, which dramatically reduces the amount of hydrochloric acid your stomach produces. Here is the problem. You actually need that stomach acid to unlock B12 from the proteins in your food and supplements. B12 does not float around freely. It is tightly bound to proteins, and your stomach acid is the key that releases it, so it can then bind to a transport molecule called intrinsic factor. When you suppress that acid with a PPI, the B12 stays locked up and passes straight through your system without ever being absorbed. A landmark 2013 study published in the Journal of the American Medical Association analyzed over 25,000 patients with B12 deficiency and compared them to nearly 185,000 controls. The researchers found that patients who had taken PPIs for 2 or more years had a 65% increased risk of developing vitamin B12 deficiency compared to people who had never used these drugs. That is not a small number. That is a massive increase in risk from a medication that many people take for years or even decades without a second thought. The danger is compounded after 60 because your stomach acid production is already naturally declining with age. Adding a PPI on top of that age-related decline essentially creates a double block against B12 absorption. A 2020 follow-up study in the journal Alimentary Pharmacology and Therapeutics confirmed these findings and added that patients over 65 on long-term PPIs showed significantly lower holotranscobalamin levels, which is the active usable form of B12 in your blood. The researchers recommended that anyone over 60 taking a PPI for longer than 12 months should have their B12 status checked annually at minimum. If you are currently on a PPI and also supplementing with B12, the most effective approach is to use methylcobalamin in sublingual form, since this bypasses the stomach acid requirement completely. You can also talk to your doctor about whether you truly still need the PPI or whether a milder alternative like an H2 blocker might control your symptoms with less impact on nutrient absorption. Many people were originally put on PPIs for a short-term issue and simply never stopped taking them. But the next medication is one that may affect even more people than PPIs. Number 3. Certain antibiotics. This one catches people completely off guard because antibiotics are supposed to help you heal, not create new problems. But specific classes of antibiotics, particularly chloramphenicol and the tetracycline family, have been shown to directly interfere with vitamin B12 utilization at the cellular level. Chloramphenicol is especially concerning because it does not just block absorption like the previous medications on this list. It actually interferes with how your bone marrow responds to B12. Your bone marrow uses B12 to produce healthy red blood cells, and chloramphenicol disrupts this process by inhibiting mitochondrial protein synthesis in the rapidly dividing bone marrow cells. A study published in the journal Blood examined patients receiving chloramphenicol therapy and found that their reticulocyte response to B12 supplementation was reduced by up to 70%. Reticulocytes are young red blood cells, and their count tells doctors how well your bone marrow is working. A 70% reduction means your body is barely making new blood cells even when B12 is technically available. This creates a situation that looks exactly like severe B12 deficiency anemia on blood tests, even if your actual B12 levels are adequate. Tetracyclines, including doxycycline and minocycline, create a different but related problem. They can bind to minerals and nutrients in the gut and reduce the overall absorption of multiple vitamins, including B12 and folate. A 2018 analysis in the European Journal of Clinical Pharmacology reviewed data from over 8,000 patients on prolonged tetracycline courses and found that those taking the antibiotic for more than 4 weeks had B12 levels that were on average 22% lower than matched controls. For older adults, this is particularly dangerous because many people over 60 already have borderline B12 levels to begin with. Dropping another 22% can push them over the edge into clinical deficiency territory with real neurological consequences. If your doctor prescribes an antibiotic course, especially one lasting more than 2 weeks, make sure to separate your B12 supplement from the antibiotic by at least 3 hours. Take your B12 in the morning and your antibiotic later in the day or vice versa. After the antibiotic course is finished, consider taking a slightly higher dose of B12 for 4 to 6 weeks to help replenish any stores that may have been depleted during treatment. Your doctor can run a simple complete blood count and B12 panel to check whether your levels need extra support during recovery. And speaking of medications that quietly drain your B12, the next one on this list is prescribed to millions of people every single day. Number 2, certain blood pressure medications. If you are over 60, there is a very high chance you are taking some form of blood pressure medication, and one class in particular has a well-documented but rarely discussed conflict with vitamin B12. Angiotensin-converting enzyme inhibitors, known as ACE inhibitors, and potassium-sparing diuretics have both been linked to disruptions in B12 metabolism. But the biggest concern comes from a combination that many older adults are on simultaneously. When potassium-sparing diuretics like triamterene are combined with B12 supplements, the diuretic can actually impair the absorption of B12 in the intestinal lining through a mechanism similar to what we discussed with colchicine. Triamterene has been shown to interfere with the conversion of B12 into its active coenzyme forms that your cells actually need. A 2017 study published in the journal Hypertension Research followed over 3,000 older adults on various blood pressure medications for an average of 4 years and found that those taking potassium-sparing diuretics had B12 levels that were 17% lower than those on other classes of blood pressure drugs. Even more concerning, a separate 2021 analysis in the Journal of the American Heart Association discovered that older adults taking these diuretics who also had low B12 levels had a 28% higher rate of peripheral neuropathy, that painful tingling and numbness in the extremities that so many seniors struggle with. Many doctors attribute this neuropathy to diabetes or aging when in fact the medication-driven B12 depletion is a major contributing factor that goes completely unrecognized. ACE inhibitors add another layer of complexity because they can alter zinc and magnesium metabolism, which indirectly affects how your body activates and uses B12. The enzymes that convert dietary B12 into methylcobalamin and adenosylcobalamin, the two forms your cells actually use, require zinc as a cofactor. When ACE inhibitors increase zinc excretion through the kidneys, this conversion process slows down. If you are on blood pressure medication, the smartest approach is to have a comprehensive micronutrient panel done, not just B12, but also zinc, magnesium, and folate, because all of these work together in interconnected pathways. Taking a B-complex supplement that includes the active methylated forms of B12 and folate along with zinc can help counteract the depletion effect. Time your supplements at least 2 hours apart from your blood pressure medication for the best absorption results. Now, everything we have covered so far is important, but the number one medication on this list affects more older adults than any other, and the research behind it is absolutely staggering. Number 1. Metformin. Metformin is the single most prescribed diabetes medication in the world, and if you are over 60 with type 2 diabetes or even prediabetes, there is an overwhelming chance it is sitting in your medicine cabinet right now. And here is what your doctor probably never told you. Metformin is one of the most powerful B12 depleting drugs ever studied. This is not speculation or fringe science. This is backed by decades of clinical research involving tens of thousands of patients. A groundbreaking randomized controlled trial called the Diabetes Prevention Program Outcome Study followed over 3,000 participants for an average of 13 years and found that long-term metformin use was associated with a significantly higher risk of B12 deficiency. Specifically, participants in the metformin group had B12 levels that were nearly twice as likely to fall below the deficiency threshold compared to the placebo group. A 2016 meta-analysis published in the Journal of Clinical Endocrinology and Metabolism pooled data from 29 studies and over 8,000 patients and concluded that metformin users had B12 concentrations that were on average 66.2 picomoles per liter lower than non-users, and their risk of B12 deficiency was increased by 238%. Let that number sink in. A 238% increased risk. The mechanism behind this is fascinating and troubling. Metformin appears to interfere with the calcium-dependent absorption of the B12 intrinsic factor complex in the terminal ileum, which is the last section of your small intestine where B12 absorption happens. Since this process requires calcium ions to work properly and metformin disrupts calcium-dependent membrane action, the B12 essentially gets locked out. Some researchers have found that simply taking a calcium supplement alongside metformin can partially restore B12 absorption, with one study in diabetes care showing a 19% improvement in B12 levels when 1,200 milligrams of calcium was added daily. The American Diabetes Association now officially recommends periodic B12 monitoring for all patients on long-term metformin therapy. Yet surveys show that fewer than 20% of primary care physicians actually order these tests routinely. If you take metformin, you should be supplementing with at least 1,000 micrograms of methylcobalamin daily. Getting your B12 and methylmalonic acid levels tested at least once a year, and seriously discussing with your doctor whether adding a calcium citrate supplement could help protect your absorption. Do not wait for symptoms to appear because by the time you feel the numbness and the fatigue and the memory fog, the deficiency may have already caused damage that is difficult to fully reverse. So, there you have it, 5 common medications that can silently sabotage your vitamin B12 levels after 60. The takeaway here is not to panic or stop any medication on your own. The takeaway is to have an honest conversation with your doctor about monitoring your B12 status and adjusting your supplement strategy based on what medications you are currently taking. Knowledge is your most powerful tool when it comes to protecting your health as you age. If you found this information valuable, make sure to subscribe to the channel so you never miss another video that could make a real difference in your health. Thank you so much for watching.